Good morning. My name is Shelby.
My name's Alyssa.
I'm Brianna.
I'm Anne, and our research is on the effects of a self-mobilization technique on shoulder, hip, and thoracic mobility during the overhead squat. First, we're going to review the biomechanics of the thoracic spine. Its main function is stability more so than mobility. This is due to being a transitional zone between the upper portion and lower portion of the body, along with being an important weight-bearing mechanism for the whole spinal column. Even with its limited mobility, the segments can move. For segments T1 to T2, there's a range of 14 degrees available for flexion and extension, and for T3 to T12, there's a range of 6 to 8 degrees available for flexion and extension. Overall, there's a range of 15 to 20 degrees for thoracic extension in the thoracic spine. Based on the anatomy of the thoracic spine, there is a kinematic link between the shoulder, cervical, and lumbar spine. What does this mean? This means if there's a thoracic spine mobility impairments, this can affect the kinetic chain elsewhere in either the shoulder or lumbar spine, then ultimately leading to functional deficits like poor body mechanics in a squat. As we were doing research on the thoracic spine, we found that research was limited on therapeutic exercises to improve thoracic mobility. A study done in 2020 by Hennigan et al. Reviewed 2,348 sources. Of that, they found only 9 exercises that targeted thoracic mobility. A study done by Bronco and Moodley, they were looking at ways to decrease thoracic kyphosis. They compared thoracic stretching and strengthening, spinal manipulation, and a combination of these techniques. The combination of the techniques was the most effective. And then a study done by Johnson and Grindstaff, they were looking at ways to incorporate self-mobilization techniques and allowed the patient to be an active participant in the rehab process. Other research that is out there, most is expert opinion based, indicating a need for research to investigate the effects of exercises on thoracic mobility in the kinetic chain. Next, we're trying to figure out how are we going to screen thoracic mobility. This led us to look into the overhead squat. The overhead squat is used in both the clinic and in research and screens the quality of movement. It does this by looking at the full body, so looking at your ankle, knee, hip, shoulder, and spine, and exposes areas of decreased stability and mobility. The 2 common screening tools that are out there are your functional movement screen and your movement competency screen. The FMS is generally seen with our athletic population, where the MCS paired with the traditional squat is more applicable to the general population. Due to previous studies using these screening tools, this led us to use in ours.
The purpose of our study was how to assess an intervention targeting thoracic mobility and how that impacts the shoulder and hip mobility during the overhead squat, and also to assess the relationship between thoracic, hip, and shoulder mobility when analyzing the overhead squat. We hypothesized that thoracic extensions on a foam roller would result in decreased thoracic kyphosis and increased shoulder mobility. We also hypothesized that there would be improved mechanics during the overhead squat due to increases in both hip and shoulder flexion during the deepest phases of the squat. The independent variable in our study was a thoracic extension intervention. The dependent variables included thoracic kyphosis measurements in standing and during the overhead squat, along with hip and shoulder angles during the overhead squat. To measure thoracic kyphosis, we used the method that had been utilized in a previous study by Lewis. In our study, one researcher held a handheld inclinometer at the spinous processes of T1 and T2, while the other researcher held the inclinometer at the spinous processes of T12 and L1. From there, each researcher recorded the measurement while the participant was standing and while they were in the deepest phase of their squat. As done in Lewis's study, final thoracic kyphosis measurements were figured out by summing the measurements at each inclinometer in each position.
For the single session intervention, participants selected laid supine on a mat table with their butt and feet flat on the mat table and knees flexed. A foam roller was placed horizontally against the lower thoracic spine. They then put their hands behind their head, went into cervical retraction, and kept their elbows pointed forward. They then completed the 10 thoracic extensions over the foam roller, maintaining cervical retraction and keeping their butt on the mat table. The 10 thoracic extensions were then repeated at the upper and middle thoracic spine. To partake in this study, participants needed to consent to being in the study, be 18 to 30 years old, and have none of the exclusion criteria. The exclusion criteria included having a history of a recent injury within the last 3 months, any spinal abnormalities like scoliosis or spinal surgery, as well as being outside of the age range. Once participants were deemed appropriate, they then completed their consent, demographic survey, and intake paperwork. They then had adhesive markers placed on their skin on the left side of the body at the olecranon and greater tubercle of the humerus. The adhesive marker for the greater trochanter of the femur was placed on the clothing. They then laid prone and had skin-safe markers placed at the T1 to T2 spinous processes, as well as the T12 to L1 spinous processes. From there, they went to the next room and had the initial standing and squatting kyphosis measurement. They then went to the following room and had the thoracic extension intervention, or they sat for the control group. Each group was randomly assigned and took approximately 5 minutes to complete. They then went back to the second room and had the final thoracic kyphosis measurement in both standing and squatting. Once that measurement was complete, they were released from our study. We then completed video analysis of the hip and shoulder angle using Dartfish, as well as data analysis using SPSS. For the thoracic kyphosis measurements, participants started in standing upright with their shoulders flexed to 180 degrees. They then completed a squat with a board underneath their heels and paused at the bottom so the researchers could take the thoracic kyphosis measurement. Image A depicts Alyssa and Shelby taking the thoracic kyphosis measurement during the squat. The angles on the screen are conducive to the shoulder and hip angles. The hip angle is a complementary angle due to Dartfish's software. So, for example, image A depicts 113 degrees of hip flexion. Image B depicts the researchers taking the thoracic kyphosis measurement during the squat after the thoracic extension intervention was completed, with a notable change in shoulder and hip angle.
With the initial statistical analysis of the subjects, we found no significant difference between the groups for age, height, weight, sex, exercise frequency, and squat frequency. We ran a mixed design ANOVA to examine the effects of the intervention on thoracic kyphosis in both standing and during the overhead squat, as well as the effects of the intervention at the hip and the shoulder. There was a significant difference for kyphosis during the overhead squat, as shown by the p-value of 0.025, and at the hip, as shown by the p-value of 0.012. There was no significance for kyphosis in standing or for the shoulder, as shown by the p-values greater than 0.05. These results demonstrate that our thoracic intervention resulted in significantly improved thoracic mobility during the overhead squat, but not in standing. However, there was still a mean decrease in kyphosis by about 4 degrees in the standing condition. A decrease in kyphosis is synonymous with improved mobility. Shoulder mobility was not significantly impacted during the overhead squat, which differed from our hypothesis. However, we did still see a mean shoulder increase by about 3 degrees into flexion. Finally, we saw that hip flexion angle significantly decreased, which was actually the opposite of our original hypothesis. We had hypothesized that the depth of the squat would increase following intervention, increasing the hip flexion angle, but what we actually saw is that there was an improvement in trunk posture following the intervention, resulting in the decreased hip flexion angle that we observed. The first concept from the study is that performing a dynamic extension exercise on the foam roller resulted in a significant improvement in kyphosis during a dynamic movement, the overhead squat. Interestingly, significance was not found for kyphosis in the standing posture. This suggests the relevance of analyzing movement rather than just static postures. A valuable implication of this study is to consider more frequent use of screening tools such as the FMS and the MCS that incorporate dynamic movements like the overhead squat or the traditional squat. Dynamic screening tools are more functional and allow one to better visualize the relationships between pieces of the kinetic chain. Based on the biomechanics of the overhead squat, we believe that improved mobility in the thoracic spine resulted in an improved upright trunk and therefore the decrease in hip flexion that we observed. It is our understanding that this study is one of the first to demonstrate a relationship between thoracic spine mobility and the hip. This finding could be particularly useful for the overhead squat lifting community specifically, as well as the overhead athlete. However, traditional squatting is an important and functional movement for most populations that this finding may apply to. Poor thoracic posture is very common among the general public and can contribute to conditions such as subacromial impingement, lumbar and thoracic dysfunction, and decreases in shoulder range of motion, pathologies that are all likely treated in an orthopedic clinic on a daily basis. Our study demonstrates that thoracic extensions on a foam roller can produce short-term results to mitigate potential consequences of poor thoracic posture. This brings us into the future use of this research and the potential physiology behind it. Our results demonstrate that performing a short course of a one-time intervention at the thoracic spine produced results throughout the kinetic chain. Specifically, we saw improved overhead squat mechanics through increased trunk angle. We believe that there is the potential for significant shoulder mobility as well. We hypothesized that we did not see significance in the shoulder at this time as a result of the other postural changes that we did see in the thoracic spine and at the hip. Shoulder mobility was not largely increased in order to compensate for these other postural changes. This is an area for future research. Potential physiological effects have been well studied in manual therapy, and we perceive that similar effects are achieved with mobilizations. This includes effects to the autonomic nervous system, such as decreases in cortisol. As we know, cortisol has systemic implications such as tissue healing and immunology, as well as emotional health. Similarly, we see increases in beta endorphins, as well as a hypoalgesic effect on tissue from manual therapy. Finally, an important implication to discuss is the conversation of mobilizations versus manipulations for treatment of mobility deficits. Mobilizations are more accessible than manipulation and may also cater to more patients due to patient comfort. Most importantly, mobilization also allows for patients to be more active in their rehabilitation and less dependent on a therapist, potentially improving patient outcomes.
Some of the main limitations in our study included the use of convenient sampling from one university. There was also a potential for measurement error as researchers had to quickly read the inclinometers while the participant was in the deepest phase of the squat. There was a potential for decreased reliability of our adhesive markers. We ended up placing some markers on the outside of participants' clothing. Although most participants were wearing tighter clothing, there was still a potential for movement of these markers. Along with this, we did not place an adhesive marker on the lateral condyle of the femur. Lastly, thoracic kyphosis measurements were only taken once in each position. This could increase the effects of bias in our study. Future research should look at using alternative self-mobilization techniques using different tools that allow for different positions. Future research should also compare the effects of manipulations to mobilizations on the thoracic spine. Goniometry should be used when measuring shoulder angle during the overhead squat. And lastly, a 3D software system should be used to see if it provides any benefit over using a 2D system when it comes to measurement accuracy.
In conclusion, supine thoracic extensions on a standard foam roller for 10 repetitions in the upper, middle, and lower thoracic spine resulted in improved thoracic mobility and decreased hip flexion during the overhead squat. Shoulder mobility was not significantly changed following thoracic extensions.
We would like to thank Clark University Physical Therapy Department, specifically Lori Hyatt and Brad Cruz. We would also like to thank our reviewers. A special acknowledgement to Ken Yasukawa for his insight and knowledge of statistical analysis.
Here are our references, and we will open it up to questions.